Welcome to the Saskatchewan Spine Pathway Clinic. I'm now going to review the primary care practitioner referral form and go through the questions on the history. So this is the back specific history. And the first question is, where is the pain the worst? And the specific way to ask this question is ask the patient to stand up, turn around, and point to where the pain is the worst. Sometimes patients will indicate their back, their buttock, and down into their leg. And if they cannot decide which pain is the worst, ask them, if I could wave a magic wand, which pain would you want to go away first, the back or the leg? And if they say the back, then they have a back dominant pain pattern. Does the pain stop forever or even for a moment? And the way to ask this question, it's a two-part question. Ask them, is your pain constant or intermittent? If they say constant, ask them, is there ever a moment when you're in your best position in the best part of the day where your pain stops and I know it comes right back, and you have to phrase it like that. When the pain stops and I know it comes right back, is the pain gone? And if they say yes, you follow that up with part B and you ask them, when the pain is gone, is it totally and absolutely gone away? Is it 0 out of 10? And if they say yes, then they have a back dominant intermittent pain, which is a mechanical problem and is benign. The next question is to ask them, what are the relieving and aggravating factors? And you should ask them if sitting, standing, rising from sitting, bending forwards, bending backwards, walking or laying down aggravates their back pain, and then ask them about the same postures and movements if any of them provide relief, as this will help you define your pattern. And quite often patients will say that quite a number of the postures aggravate their back pain. Ask them which is the most aggravating. And again, some may provide relief. Ask them which provides the most relief. Is there a previous history of back problems, and were they back dominant or leg dominant? The next question is, has there ever been previous treatment or surgery for their back problems? Quite often, if they've had a certain type of conservative treatment, such as massage or physio or chiropractic, and that's been helpful, and they're having a similar type of back pain, then quite often that kind of treatment will help them for their present bout. Has there been a change in their bowel and bladder function? So you need to ask very carefully about this. Can they pee when they want to pee? Can they stop when they want to stop? Do they have control of their bowel and bladder? Sometimes early on, especially in cauda equina syndrome, they have bladder retention, which means they cannot pee for the first 24 hours. So you need to ask very carefully about this question. And again, sometimes patients will say yes to bowel and bladder problems, but you need to ask them if there are recent changes. If you have, for example, an older woman that's had several children, she may have stress incontinence. That may be long-standing for several years. If she coughs or sneezes, she may leak a bit of urine. But again, this is a long-standing problem that was present before the back pain, and there's been no change. So again, there's been no significant change in her bowel or bladder function. The next question is to ask them, what is their overall level of disability when it comes to activities of daily living and to work? Are they able to perform all of these activities without limitation, or do they have mild, moderate, or severe limitation? And is that due to their back or leg pain? The last question is to ask about red flags, if they're present, and if so, are they an urgent surgical candidate? So do they have possible cauda equina syndrome, which would entail severe sciatic pain down both legs with bowel and or bladder dysfunction? And on physical exam, do they have loss of anal tone or fecal incontinence? And do they have saddle anesthesia, both anus and perineum or genitals? And do they have urinary retention with overflow incontinence? Welcome to the Saskatchewan Spine Pathway. We are now going to review pattern recognition. The first pattern we'll review is the pattern 1 fast responder. And in this case, the patient will report intermittent back dominant pain, and the pain can be in the lumbosacral junction, refer down into the buttock, into the trochanter, and into the groin occasionally. The most common spot is in the back and maybe down into the buttock a bit. This patient, on testing, the first thing we'll do is we'll look at the spinal curves. We're looking for normal spinal curves. Does he have a normal lumbar lordosis? Do they have a normal thoracic kyphosis? And on range of motion testing, just bend forward for me, please. Is there a normal lumbopelvic rhythm? Come on, back up. So a normal lumbopelvic rhythm is they bend forward at the lumbar spine, and when they reach the end of that, then they rotate at the hips, and then they do the opposite. They re-rotate at the hips, and the spine re-extends. And that's a normal lumbopelvic rhythm. When we're doing the observation, if they have, let's say, a pronounced thoracic kyphosis, that could be something like Schurman's kyphosis that you see in younger adults, or you could see it in an older, much older 70 or 80-year-old lady or man with thoracic kyphosis from osteoporotic fractures. And quite often in mechanical back pain, especially if it's acute, they quite often have a shift. They're shifted over to one side, or they're kyphotic in their lumbar spine. And that's what you want to look for on observation. So you have to have them take their shirt off and look at their lumbar spine. Stand up straight for me. Then you observe their range of motion and their lumbopelvic rhythm. And after that, what we're interested in finding out is if this is a pattern 1 fast responder, when they bend forward, this is a loaded position that aggravates their typical back pain. And what will happen is either the back pain will increase, or it will increase and it'll peripheralize, which means it'll travel out. When back pain peripheralizes and it travels out from its central source, that means it's getting worse. And it can centralize, which means it travels back towards its original site. And we'll review that in just a second. So loaded flexion will make them worse. And just put your hands on your hips. Right back there, good. And just bend backwards for me. And we have them do loaded extension. And that quite often will cause their pain to reduce, or it'll centralize. And that's one thing that you have to take note of. If the back pain comes out of their buttock and goes into their back, even if it makes their central back pain worse, if it's come out of the buttock, if it's disappeared out of the buttock and drawn back up into the spine, that's still a good response. Although the patient may say that their back pain is worse, it has centralized. So that's what you're looking for, that the back pain either centralizes and or reduces. Okay, and so with a pattern 1 fast responder, they're worse with loaded flexion and they're better with extension. And have a lay down there for me. They're also frequently worse. This is unloaded flexion. Grab a hold of your knees for me, please. And that'll make their back pain, their typical back pain, worse. And this is flexion in the unloaded position. He's laying down, so grab a hold of your knees. And I ask the patient to perform 5 repetitions. Relax, put your head back. Okay, and no, hang on, please. And so the patient needs to understand that this is a passive movement. They're not using their abdominal muscles. They're using their arms to pull them up into a flex position. And the patient performs 5 repetitions. And we want to know if the location or the intensity of their back pain changes. So they do 5 repetitions. And then I ask the patient, did that change the location or the intensity of your typical back pain? And in a pattern 1 fast responder, they'll complain of increased central back pain, or they may say that their back pain spread out into their buttock, into the trochanter, or into the groin. The test following this is unloaded extension. If you could turn over on your stomach for me, please. And it's very important that you perform this test in a very exact manner. So we ask the patient to lay prone and relax. They need to lift their elbows just a bit, and their hands have to be out in front of them, and they push up, and they have to lock the elbow. So back down. So push up, Lock the elbows. The pelvis is left down. They must relax. They can't use these back muscles. They have to be relaxed. So, back down. So, push up, lock, breathe out. So when they breathe out, their stomach will sag and they'll feel their back relaxing, and back down. And they do 5 repetitions. So push up, lock the elbows, breathe out, sag, back down. Push up, lock, breathe out, hold it for a second or two, back down. And again, the patient will tell you that their back pain reduces, their typical back pain reduces, or as well it may centralize. It comes out of the buttock or out of the trochanter and draws back up into the central back. Pattern 1 fast responder is usually intermittent, and the neurological exam is non-contributory. It's essentially normal, and we reviewed that in the previous chapter, so if you could refer to the previous chapter for a review of the neurological exam. The neurological exam needs to be performed, but it'll be non-contributory. Welcome to the Saskatchewan Spine Pathway. We are now going to review treatment for the Pattern 1 fast responder. The first treatment position is in standing. This is often the easiest position to treat people in because people are quite often upstanding during the day doing their usual activities. So the patient puts their hands on their buttocks, and as they bend backwards, they push through their hips and bend back like that, causing their back pain to reduce or centralize. That's the first position. Now, another common treatment method applied to the fast responders is, have a seat for me. Sitting is a frequent cause of back pain in Pattern 1, and there's studies to show that when you put discs or when you put needles into the discs of living people to measure the pressure is highest in the discs when you're sitting, especially if you're leaning forward and you have something in your hands. So in order to reduce the pressure in the back, they can roll up a towel, put some tape on either end to hold it in place, and the patient places it, usually you have to place it down low at the L5 or at the S1, and the bigger the roll, usually the better it works, and you can see how that helps maintain his lordosis. And Pattern 1 fast responders will tell you immediately that this helps reduce their back pain. And this is a treatment for people that have to sit frequently at work. Okay, I'll have you stand up for me. The next position that we'll review is in laying. If you can lay on your stomach for me, please. And in this position, the client will do the sloppy push-up or the prone passive lumbar extension. So they'll lift their elbows, lock their elbows, breathe out, let their back and stomach sag, and they hold it for a second or two, and then back down. And their pelvis is meant to stay on the bed. So push up, lock, breathe, sag. Back down, push up, lock, breathe, and sag. And 5 repetitions is usually enough to make the back pain reduce or centralize. And they should do this, if they can, every hour or at least 3 or 4 times a day. We'll now review the treatment principles for Pattern 1 slow responder. And this type of patient, their back pain on history is worse with flexion, and when you do the physical exam, they're worse with flexion and extension. And what happens over time is these patients have a back that's quite sore and it stiffens up, so hence they have pain on both flexion and extension. So the best way to start these patients is in a supine unloaded position. And when you reference the exercise sheets, you'll see on the one side that they have a number of exercises, and the first one is knees to chest. And this is the easiest way for them to start mobilizing their spine. So they relax, they do all the pulling with their arms, and they pull in. So they pull right up to discomfort and then let off. Next, we'll review the next unloaded test for the pattern 1 slow responder. And this is prone passive lumbar extension, or the sloppy push-up. And we'll have the patient push up, lock their elbows, breathe out and sag, and hold it. And back down, the pelvis stays on the ground. So push up, lock the elbows, breathe out, let everything sag, and back down. Hold it for a second, good. Hit, push up, lock, breathe out, let everything sag, and back down. And this will make their typical back pain worse. So next we'll review the treatment principles for the pattern 1 slow responder. And if you reference the pattern 1 sheet, on the one side there's a number of exercises, and we'll begin with knees to chest. And the first exercise, the patient grabs a hold of their knees and they use their arms, their stomach muscles are relaxed, they pull in to the point of discomfort and then they let off. And with each succeeding repetition, if they can pull just a touch further and begin to loosen up their back that way. And you have to tell the patient up front that their back is very stiff and that this type of back pain takes longer to treat, and that if they keep at it, it'll slowly but surely loosen up. The next position is a Z-lie, and quite often the patient finds this very comfortable. You can see how they call it a Z-lie because their legs are in a Z position. So this chair is pushed up and their legs are back like that, and it forms a Z. And quite often they find this position comfortable, and we would refer to this as an escape position, that they can do their knees to chest, and then they can put their feet up on the couch or the bench and rest and reduce their back pain. And another position, once they become more comfortable, is the box lie, where their legs are at a 90 degree. Okay, just take your legs off that. Another possible rest position for these pattern 1 slow responders is having their legs up on pillows like this. And then as they become more comfortable, as they're able to move their back more, we can switch them over into a prone on pillows. I'll get you to turn over on your stomach. And what we'll do is we'll put pillows underneath their hips. And you can see how that keeps their spine in a somewhat flexed position. And they need to frequently do this over the course of the day, at least 4 times a day. And as they become more used to this, as their back pain reduces, you can take out a pillow. And I'll predict for the patient that when I take out that pillow, they'll have some increased back pain. Over time, their back will stretch out and they'll get used to it. And then when that happens, I'll take out another pillow, and then they can work towards laying prone. And once they can do that, then we could proceed back to, lift up your hips for me. We can put some pillows underneath their hips, and then we can start the prone passive extension. And they start with prone on their elbows, and they're extending somewhat, but these pillows are under their hips to reduce some of the extension, and it's easier for them to tolerate. And again, this is the power of prediction. I will tell them that they'll have a bit of increased back pain, and then over time that will stretch out, and they can go on to the next level or the next progression, which is I'll take out one of the pillows and up onto your elbows, and they can proceed from there. And then they can take that pillow out, and then they're up on elbows there, and then eventually what they do is they'd work themselves up into the usual sloppy push-up position. Welcome to the Saskatchewan Spine Pathway. We are now reviewing pattern recognition, and we're looking at pattern 2. This is a back dominant type of pattern. So the patient will complain of back dominant pain. This pain is always intermittent, and this pain can be central back pain. It can radiate into the buttock, and less commonly into the trochanter or into the groin. This back pain, when you do the physical exam, put your hands on your hips and bend backwards. They're worse with extension, and when they bend forward, they're no worse or better with flexion. A treatment position for pattern 2 would be in lying. And the first position, if they're fairly acute, you can start with the Z lie. Here, again, there's that Z position of the legs. The knees are quite flexed, and this has the pelvis turned, so it in turn flexes the lumbar spine. And if they're quite acute, they'll find this comfortable. The other position, or the other movement, I should say, that they can use is knees to chest. Make sure they don't use their stomach muscles. They do all the pulling with their arms, and relax. And they're pulling until they find the most comfortable spot. And it doesn't matter for the patient. They don't have to pull as hard as they can. They're just looking for the sweet spot, the point at which their back pain is reduced or abolished. And quite often, patients find it difficult to lay down at work if they're at work. And another position they could use is the seated flexed position. So what they can do is they can start in a seated position, and they can put their elbows on their forearms, or their elbows on their knees, and they can flex forward and down like that. And again, they lean forward as far as possible. That reduces their typical back pain the most or abolishes it. Welcome to the Saskatchewan Spine Pathway. We are reviewing pattern recognition. We are now going to review pattern 3. In this pattern, the patient will complain of leg dominant pain. So that's below the gluteal fold into the leg. So they complain of constant leg dominant pain. And when they flex forward, that will make their leg pain worse. And sometimes what will happen is that pain will peripheralize. It'll travel even further. If it's in their calf but not in their foot, it may travel into the foot. That's called peripheralization. And when you extend them, that may or may not aggravate their leg pain. Now, have a seat up here for me. In order to diagnose pattern 3, you have to have constant leg dominant pain, and as well, they have to have a positive irritative test, namely the straight leg raise. And you can do the straight leg raise test in sitting, and quite often, when I go to do the Babinski's test, I will lift up their leg. If they have leg dominant pain, they won't let you fully extend it. And in this leg, they will let you fully extend it, and you can do that test. Here, they'll complain of reproduction of their typical leg dominant pain. I'll have you lay down for me. In order to test the straight leg raise in laying, we have them straighten out their leg. The other leg should be bent for a comparison against sitting. And when I go to lift the leg, the patient will stop me and they'll complain of reproduction of their typical leg dominant pain. And this could be anywhere from 10 degrees up to 110 degrees. Quite commonly, people are taught that anywhere from 0 to 30, you can't have a positive straight leg raise, but you can. And sometimes people are quite flexible, and occasionally, rarely, you can have somebody, their leg can come all the way up to 100, 110 degrees if they're quite flexible. And If it reproduces their typical leg dominant pain, then you would consider that a positive straight leg raise, whether it's at 30 or 100. And they may or may not have conduction loss. So when you do the rest of the neurological exam testing muscle power and reflexes, they may or may not have diminution of a reflex or loss of a reflex, and they may or may not have motor power loss, but they must have constant leg dominant pain, and they must have a positive straight leg raise test. Now, next we'll look at some treatment positions for pattern 3. And in this, the first and probably easiest treatment position is Z-lying. And again, you can see how the knees are flexed, and that forms a Z position. And I have to stress that pattern 3 is treated with posture, not movement. This is the kind of treatment where they need to spend at least 20 minutes out of 1 hour in whichever position relieves their or reduces their leg pain the most. So with this kind of positioning, they'll have reduction of their leg pain, but not abolition of their leg pain. And this Z-lie is quite often one of the positions that works very well. Now, some of the other positions that you could try, you can just put your feet down for me. I'm just going to get you to turn over and go on all fours for me. At times, in the 4-point stance, this position will be quite comfortable for a patient with leg dominant pain. You can trial that. Another position that may be comfortable for them is laying prone with pillows under the hips. This holds the spine in a fairly neutral position. And one last position that you could try is up on your elbows. And let's just take these pillows out. With or without the pillows, they could go prone on elbows. And again, if this reduces their typical leg pain and they find it comfortable enough, again, they can use this as an escape position. And again, they should use it for 20 minutes out of every hour. Unload their spine from gravity and reduce the irritation and the pain in their leg as much as possible. Now, as the pattern 3 patient begins to recover, you'll find centralization of their leg pain. So what happens is the pain comes out of their leg and travels back up into their back. It centralizes in their back. And once the pain starts to come out of their leg, if it's for the most part left the leg and they're complaining of more back or buttock pain, they've become back dominant, then you can switch the treatment protocol into the pattern 1 treatment exercise. And those are referred to in an earlier chapter, which you can review on how to progress the patient once their leg pain has centralized into their back. Welcome to the Saskatchewan Spine Pathway. We're reviewing pattern recognition. We are now looking at pattern 4. Pattern 4 is also known as neurogenic claudication, and typically this is an older patient, and their physical exam is unremarkable. This is almost exclusively done by history. The patient will complain of leg dominant pain, so that's from the gluteal fold down. They'll complain of leg dominant pain. They'll complain usually of pain in both legs. Occasionally it's in one leg, but most often both legs. And this pain is aggravated with extension type activities, particularly walking, and it's relieved with flexion type activities, particularly sitting. So the client with pattern 4 will frequently tell you that they can walk 1 or 2 blocks and then their legs become progressively painful. They have dysesthetic feelings in the legs, and they may have progressive weakness. And when they get to the limit of their walking ability, they must sit down. And contradistinction to vascular claudication, which is a problem with the blood vessels, these clients, all they have to do is stop and stand still, and their symptoms in the legs will abate. But with neurogenic claudication, the patient actually has to sit and flex their spine, because that opens the spinal canal and takes the pressure off the nerve roots, and that relieves their leg pain. And after sitting for a while, they can get up and walk their 1 or 2 blocks again. So commonest treatment that works for pattern 4 is to have them sit. So quite frequently, you teach them to flex in the seated position, and again, they're looking to lean forward however far is required to reduce or abolish their back and leg pain. And pattern 4s are always intermittent, so their leg pain comes on with walking. As soon as they sit, especially when they flex forward, their leg pain abolishes, goes away. So they can use the seated position to treat themselves. Come and lay up on here. And because this is typically a bony structural problem, this is a long-term management problem, and they need to learn how to manage it through abdominal strengthening and flexion exercises. So again, to abolish their back and leg pain, they can use flexion and lying as well. And in order to strengthen their abdominal muscles, they can learn how to do the pelvic tilt, which is tightening the stomach muscles. And you can see how his pelvis rolls back, and he's using his stomach muscles to tighten and flex the spine. And that way you can hold the spine in a bit of a flex position and reduce some of the pressure on the nerves in the back. And the other position or the other exercise they can learn is crunches, where they can put their hands behind their head and they can learn to roll up. And again, that's strengthening the stomach muscles. Frequently people get pain in their neck, so we quite often teach them to hold on to their neck, or they can use a towel as well if they can't get their arms back that far. Good.